Eh, la idea de de nuestra presentación ahora es un poco ver digamos, la información que se genera, digamos, o que vamos generando dentro de los sistemas, dentro de los distintos sistemas. Muchas veces cuesta que el médico llegue a encontrar, entonces, digamos, o tenga que leer cada una de las cosas o toda la información que se genera sobre el paciente. Y ahí es donde empiezan a surgir, digamos, donde empezamos a evaluar un poco este teorema de la informática médica, digamos, de que el cerebro del médico más la computadora es mayor que únicamente el médico, y empezar a ver cómo sumamos sistemas de soporte a la decisión. En este caso, digamos, lo invitamos a Guilherme del Fiol, es un referente de todo lo que tiene que ver con sistemas de soporte a las decisiones, digamos. Es, digamos, como para darles un contexto de Guilherme, digamos, él es un médico graduado de la Universidad de San Pablo, digamos, de Brasil. Tenemos un par de Guilhermes hoy de Brasil, que nos van a dar su experiencia. Digamos, más tarde a la tarde tenemos al Char de HL7 Brasil, que también se llama Guillermo. Y hizo la maestría en Ciencias de la Computación ahí en la Universidad Católica de Paraná en Brasil, y después hizo su doctorado en la Universidad de Utah, donde hasta ahí fundó bases y actualmente es profesor asociado y vicepresidente del Departamento de Investigación de Informática Biomédica ahí de la Universidad de Utah. Y propiamente desde el 2008, ya hace como 12, 13 años, está trabajando en HL7 como co-chair del grupo de Clinical Decision Support, ¿sí? Digamos, en un trabajo que viene y pasó por todas las etapas, digamos, cuando el Decision Support que hacía con Open CDS o hizo la primera parte de Infobuttons, digamos, fue uno de los autores y el foco principal de él fue en todo lo que tiene que ver con decisión support para la prevención del cáncer. En este caso, digamos, estos sistemas de soporte a decisiones fueron avanzando y actualmente, digamos, se usan o se arman usando Fire, ¿sí? Entonces, digamos, la idea es que Guillermo nos cuente cuáles son los estándares que están iniciando en este inicio, en esta reestructuración de lo que son los sistemas para soporte a la decisión. Guillermo made the presentation. Thank you to be here, and we're very glad to listen to your presentation.
Thank you, Firka. Thank you so much for inviting me. Can you hear me well?
Yeah, perfect.
Okay, fantastic. So yeah, it's always a great honor to present in this conference, especially presenting after Ed. That's a major honor and a responsibility. So I'm going to talk about, we've been working on standards for clinical decision support, I don't know, for many, many decades. And always with the dream of being able to share clinical decision support logic, capabilities that work well and help people's lives in one institution and then share with other institutions. But we've never really succeeded. I think we have now a stack of standards at HL7 that can, I think, finally made this dream come true. Okay, so let's, okay, so starting with short definition, this is from Jerry Osheroff, probably the most widely adopted definition. I'm not gonna read it, but the main point here is just to open up the scope of clinical decision support to, it's really any kind of application that helps clinicians or patients make and carry out decisions well beyond alerts and reminders, for example. In fact, most clinical decision support, I would argue, should not be presented in the form of alerts. And we'll see a few examples of that. Okay, we all want to share CDS, especially when it works and it helps save people's lives and improve healthcare and reduce costs. So that's our holy grail, but it's actually very difficult to share. Electronic health record systems have been historically designed with tightly coupled components you have the EHR data locked into the system. You might have CDS logic written in proprietary formats, and also CDS capabilities, the functions that execute CDS, also written in proprietary languages or in a way that they're just not shareable. Even when two different healthcare organizations use the same electronic health record product, oftentimes they're still not able to share CDS logic and capabilities in an efficient way. For example, in our institution, we oftentimes try to share CDS logic with other institutions using the same EHR, and the best sharing mechanism we have is screenshots of the EHR build for the CDS. So I'm going to talk about 3 emerging CDS standards. Some of them are a little more mature than others, but they together compose an interesting ecosystem that allows multiple ways of sharing. And I'm going to show how the architecture looks like. Smart on Fire focuses on sharing apps. So very much like you have apps on your phone. CDS hooks allow the sharing of CDS capabilities in terms of web services. So you can have an electronic health record calling out an external web service that provides CDS logic. And then clinical quality language is really it's like a programming language for CDS that allows you to share CDS logic itself. So it's a knowledge representation formalism. Okay, Smart on Fire. It's composed of 2 distinct standards. The SMART standard allows application interoperability. So basically, it allows a user to launch an app within an EHR with a single sign-on, so using OAuth 2.0, and that allows the EHR to pass credentials to the app. The app basically runs within the EHR frame. And Fire, within Smart on Fire, as you probably know, it's for data interoperability. So it allows an app that gets launched and with that, it gets access to the EHR Fire server. And so the app can query EHR data using Fire. Okay, so this is an example of a Smart on Fire app that's live on our system at the University of Utah. The app helps neonatologists with the management of neonatal bilirubin. You see that you have a smart launch option here on the left side. You click and it automatically launches the app here in the middle. You see that the user is still using the EHR. It doesn't look like this is loading an external app. So I'm going to walk you through a few of the highlights of this app. It basically pulls all the patient bilirubin levels automatically from the EHR. So those are lab results. You see the blue line here shows the curve. Ideally, this patient would be below these threshold lines. We got a green line and a red line for bilirubin thresholds. You see that they change over time as the baby hours after birth. And they are patient specific based on the patient's risk. Okay, this is. The yellow bar indicates that this patient has received phototherapy, which is used to treat hyperbilirubinemia. So you see that the bilirubin levels went down after that. And then on the right side, the app pulls data automatically from the EHR. These were auto-populated based on what was on the EHR, and they're all risk factors for hyperbilirubinemia. So the curves change, they adapt to the specific patient risk factors. The provider can still override these if the data are incorrect in the EHR, but they're all pulled automatically. Down here, you have a recommendation and a risk prediction. So a recommendation here based on the patient's risk factors and the bilirubin levels. And down here, there's a risk score with a prediction for rebound hyperbilirubinemia. So many decision support functions integrated into this app. It automatically pulls all the relevant data, displays in an intelligent way that makes it easy for clinicians to identify patterns, provides a recommendation and a prediction. This is a paper on JAMA where we did a study on this app. We looked at several outcomes. We looked at adoption. 92% of the patient encounters with newborns, the app was used. And then looking at efficiency, it saved providers time, also increased compliance with evidence-based treatment, and high satisfaction from providers. So CDS hooks, it's a slightly different approach. I'll show an example of a flow with prescription for a hypertension medication. Let's say a provider is ready to sign this prescription. That automatically triggers a request in CDS hooks format to a CDS service, which includes an access token to a FHIR server. The CDS service now can compute logic based on what's happening in the EHR. It can pull data from the FHIR server using that access token, and then it returns what's called the CDS cards. They're basically the conclusions of the CDS service. The cards can take multiple forms. It can be a very simple information card. For example, this is just saying the cost of the drug. The second card is a suggestion card, so it gives some kind of information. You know, you might consider changing this medication to hydrochlorothiazide because it's the first choice for hypertension, and this patient does not have any other antihypertensive in the record. And the button, by clicking on the button, the provider can change the prescription. And last, a card can have a suggestion to use a Smart on FHIR app. So that gives a good example of how these two standards can synergize with each other. You have a CDS hook service offering, recommending the use of a Smart on FHIR app. Again, a few examples, an information card with some recommendation about the patient's genotype and certain medications. A little more advanced card with a suggestion. So it's recommending not to use lisinopril and instead use this amiloride. And the provider, again, can click here and that will lead to change the prescription. And finally, an app card that they can click down here and launch the Smart on FHIR app. So CQL is, again, a different approach that allows, instead of apps and CDS services, it allows sharing CDS logic. So you can think of a library of CDS logic that can be hosted somewhere in some kind of a web-based repository, and different systems can go there and download the logic, import into their systems, and either run natively or they can translate into other languages. It's intended to be human readable, and for those of you who are familiar with previous approaches to knowledge sharing, this is kind of equivalent to Ardent Syntax and Jello. CQL uses FHIR as the native data layer, so it makes interoperability much easier. It addresses what used to be known as the curly braces problem that way. And there are authoring tools that are now becoming available. There's also a national repository of CQL logic in the US called under the CDS Connect program. This is an example of CQL. I'm not going to get into details, but the whole idea is to make it as human readable as possible. You see here a definition of an inclusion criteria for the patients who should be assessed under this logic, and it's written kind of in human readable format. Okay, I'm going to show a few architecture slides just to show how these different standards play out individually and as a group. First, with Smart on FHIR, we have a user accessing the EHR. They launch the app just like the bilirubin one. And with that, the app receives an access token, and the app gets access to the FHIR server. And they can pull data from there and display to the users. You can also save data back if the EHR allows. it's kind of a simple architecture, becoming more popular. EHR vendors are now, many of them have app stores that customers can go and download apps and install in their EHRs. With CDS hooks, again, we have a user performing some kind of function in the EHR. For example, they open a patient's record. A patient view hook is automatically triggered, and that makes the EHR call a CDS hook service. The service gets access to the FHIR server. They can pull data from that server in FHIR format, run logic, and then return back a card that the EHR decides whether or not to present to the user. With CQL, what we have is the ability to, the EHR is running all those different components locally. So instead of having an external CDS hooks service, it actually runs CDS capabilities and services internally. The EHR data is also internal. There's no, not necessarily a FHIR server here. And the CDS logic, however, is imported from a CQL repository, and then it's executed natively. So that's a different way of sharing CDS logic or CDS in general. An EHR system can go and, or a healthcare organization can license CDS logic from a publisher and then download the logic into their EHR. Next, we have the ability to share. This is mixing two standards. So we're using Smart on FHIR to share apps, just like in the previous diagram. But the app, instead of running proprietary logic internally, it actually uses CQL that could be either written by the app vendor or imported from an external organization. So here we have both Smart on FHIR used to share apps and CQL to share logic. Here we're mixing CDS logic and CDS services. So we have the CDS hooks architecture, but the web service, instead of running logic in some kind of proprietary or non-CDS format like Java, it actually runs CQL natively, and that CQL logic could have been imported again from some kind of public or proprietary private repository. Here's a diagram where we mix all three of them. So again, we have the Smart on FHIR app being launched. It could be the Bilirubin app. We have data retrieval. So in the bilirubin example, the app is pulling data from the FHIR server, pulling all those bilirubin results, for example, and the risk factors. The CDS hooks service computes some logic. For example, the treatment recommendations for bilirubin management and the risk prediction, those could all be delegated to an external web service as opposed to running inside the app. And the logic that drives those recommendations and risk calculation could be written in CQL, and that CQL could have been imported from an external repository. So it's a very nice, because these standards were developed kind of in parallel, it was possible to orchestrate them and making them in a way that they could synergize into a larger CDS ecosystem. That's unlike previous approaches where usually standards were developed in isolation. There have been a few interesting pilots that were coordinated by the Office of the National Coordinator of Health IT in the US, focused on CDS for opioid prescribing. And you have a few examples where all those different approaches were exercised. So we have direct CQL execution at Indiana University using the Cerner system. They found that that's faster than calling out an external web service. That's an advantage. But you require, the EHR needs to be able to run CQL natively, and not, most EHRs don't have that capability currently. Then we have examples from Yale, from Duke, running Epic using CDS hooks, and this internal logic of the CDS hooks web service was expressed in CQL. And the advantage here is that you have increasing EHR vendor support for CDS hooks. That's already happening in production systems. And last, at the University of Utah, we use an approach combining all three, and it's exactly the same logic. All these sites use exactly the same CQL logic in the same CDS hooks web service. At the University of Utah, we added a Smart on Fire app that can be accessible anywhere in the EHR. Okay, let's look at a few screenshots to show how this works. This is the simplest implementation. It's CDS hooks web service with an information card, basically recommending the provider to change or to avoid or reconsider the prescription of opioid. This patient already has prescriptions for opioids, but it's a passive alert. It doesn't provide any actionable element. This is a second implementation here using a suggestion card. You see that it's integrates information from the record, so it's a little more elaborate. You see this first bar is basically showing that the current patient oral morphine equivalent dose is 192 when the recommended is to be less than 50. And down here, it shows the patient's the active prescription and also the medications the patient's on. So it's bringing relevant information to display. You see that this card is formatted, it's not a simple text alert, and the provider has the option to cancel the prescription. And last, we show the option of launching a Smart on Fire app. So you see here, opioid down here from within the EHR. It looks very similar to the suggestion card, but here a clinician can, before they even go through the trouble of prescribing an opioid, they can actually check the recommendation from the app. And with this patient, you see that the current morphine equivalent dose is a little lower, but still, you can still prescribe that, but you need to reassess. It also shows the current opioids that the patient is taking. And again, it shows how that calculation was made with the patient's total morphine equivalent dose. Okay, that's what I had to talk. Any questions?
Okay, thank you, Guilherme. We have one from Andres. Do you know how many electronic health records in productions are using these standards? Smart on Fire and CS hooks?
Yeah, I don't have numbers, but Smart on Fire is definitely the most mature. It was the first one to be developed. I think it preceded CDS hooks by a couple of years. The major EHR vendors in the United States all support Smart on Fire. Even the vendors that target the smaller clinic market already support Smart on Fire. So definitely the most mature. And most of these EHR vendors also provide some kind of app store where these apps can be published. The bilirubin app, for example, is available on the Epic's App Store. CDS hooks, again, probably 2 years behind, but the major EHR vendors, I know at least 3 in the US that now support CDS hooks. So that's also quickly, it's incredible how quickly these standards were developed and adopted. I mean, it used to take a decade to see that level of adoption that we're seeing now. CQL, it's a little farther behind. It's being really strongly adopted by the US federal government for quality measures. That's, I think, what's driving adoption the most. Most systems do not have the capability to execute CQL natively, but it's used as a translation language. I mean, you can have the logic expressed in a computable format and then translate it into some kind of native language that EHR supports.
Okay. And do you know any experience outside the States, in the rest of the world?
I have not seen much. The connectathons for CDS hooks, mostly US companies, although many of the companies that are participating are international, especially the publishers. The publishers are investing heavily on, you know, what used to be the medical literature publishers, the basically textbooks and journals, are now gravitating towards executable knowledge. And these are all international companies. I mean, it's a matter of time to start seeing those target the international market.
Okay, thank you. I think there are no more questions in the chat. So thank you, Guilherme, for your presentation.
You're welcome.
Nice to have you here. I hope you come back. You came to Argentina sometimes in the future to join us.
I hope next time we'll be able to travel.
Yeah, we hope so. So thank you very much.